Hi, very good evening to everybody. I hope that all of you are doing well and your preparations are. Hello, Gokul. I hope your preparations are all right on track and you are doing well. So, good evening, Gokul. So, what to do now is today I'm going to take up certain important questions in the form of quizzes. Hi, nice tea. So, we are going to do some questions in the form of quizzes, right? Good evening, Thor. Good evening, Vijeta. Right? Yes, good evening. Good evening, Dr. Ravi. I hope all are doing well and your preparations are right on track. Okay, right. So let's start first now. So it is targeting in the quiz time in two parts. Good evening, Mugundhan. So in two parts we are going to do this, and today we are going to target certain topics, and tomorrow the other rest of the topics. Now, what I want you to do is, because it's a quiz, you will be given few seconds to answer. Try and attempt. Even if you think you do not know the answer, just try and attempt here, because this is going to actually test your recall and make you revise also the topics. Okay? And we are going to discuss important points around those questions. So good to go. Before I start, actually, there are few announcements about the subscriptions which are going on the Unacademy app. The first one is the Unacademy goal, and the target is the next batch, the next one, right? Which is of duration of 7 months, and the offer price is 9,600 on that. The second one is target FMGE batch of duration 3 months, and the offer price on that is 4,400. And you can avail this from 22nd to 26th of May. So you can subscribe and use the code NPG10 to get additional discounts. The second announcement is for the second subscription, which is target FMG 2023 batch, which is very rapid high yield revision batches of 3 months duration over 200 plus hours of the content here that you get. So here you get it for the offer of 4,400, and again you can use the code NPG10 to get further discounts. The third one here is the next one, whether it's the next 23 or the NEET PG 24, whatever which is going to be held, and that access you can get for about 9,600 rupees. Again, you can use the code NPG10 for that, right? And it is live basically on since 25th of May. So you can get theory and practice questions, and a lot of high yielding topics will be discussed there. So any of the subscriptions, if you're interested, you can make the use of it. So now jumping into the pharmacology quiz for today. So let's start, and I would like all of you to respond to it. A new drug just tested was found to have a therapeutic index of 40. Which of the following statements best describes the therapeutic index of a drug? Option A, B, C, D. Yes, please. Read options carefully and tell me which of this describes the therapeutic index correctly. Dr. RJ says D. All right. Thor says A. Dr. Ravi says D. Gokul says D. Homo sapiens D. Varun D. Nature with Medicos D. D. Yes. So most of you are correct. So the correct option is option number D. So option number D. This is the LD50 over ED50. Okay, please do not make the mistake. A is not the, I know why you said A. A actually is area under the curve of the plasma concentration graph. Can you tell me what is A? Yes, you're all correct. Dr. Mukesh, Vijaya, yes. Can you tell me what is A? Yes, Vaishnav, that is absolutely correct. What is A? Denote area under curve of the concentration time graph. So this is, let's say, the plasma concentration, and this is the time. ये हमारा एक ग्राफ है, right? So this is the AUC, area under curve. What does, very good Varun, very good. Dhwani, what is it for the NEET PG aspirant? This today's lecture, if you're talking about, yes, definitely it is for the NEET PG. The questions are overlapping, right? So definitely it is for them. So area under curve, yes, area under curve, it is tells you about the bioavailability. Or bioavailability, what does bioavailability tell us? It tells us about the extent of absorption. Yeah, another important question which is asked quite often, what does the bioavailability denote, or which of these denotes the extent of absorption? And the option is here, or the correct is bioavailability. Now, agar if I talk about this here, let me make it a little straighter. So this point here represents the Cmax, and this point here represents the Tmax. Now, out of these two, which represents the rate of absorption? Which of the following represents the rate of absorption? Cmax or Tmax? Yes, please. Fast. Very good, Gokul. Tmax. So Tmax will tell you about the rate of, no, not Cmax. Cmax is only telling you the maximum concentration achieved. So basically can be for safety. But kitni jaldi wo concentration has been achieved is your Tmax. That means rapidity, how fast the maximum concentration is achieved. So that is your rate of absorption. That is determined by Cmax. So please make note of these two things also, very important. Extent of absorption is denoted by bioavailability, but the rate of absorption is denoted by the time which is acquired to reach the maximum plasma concentration. So this is about discussion about the first point. Okay? Second one, dividing the amount of drug by the plasma concentration. So if there is a formula which says amount of drug divided by the plasma concentration. So what does this formula signify? Kiska formula? What does this formula signify? It is representing what? Amount of drug divided by the plasma concentration. Dosage, that is the amount of drug, right? Amount of drug that you're giving. Very good, Varun. It is the volume of distribution. So this is the formula for, yes, very good, Dhaval. This is the formula for volume of distribution. So this one, second option actually is not therapeutic index, but this is volume of distribution. This was bioavailability. Now, definitely it is not calculated from the half-life of a drug, because I will tell you these three formulas are important. Half-life ka formula is 0.693 multiplied by volume of distribution divided by the clearance. So here nowhere you see therapeutic index. So therapeutic index has no relation with the half-life of the drug, right? So if therapeutic index here, that is percentage of response in the population, and percentage, and this is the dose. Okay? So let's say this is the efficacy or the effect, which is the response, and this is the toxicity here. And let's say ये है हमारा 50% of the population. So 50% of population, the effect was seen at, let's say, dose 1. In 50%, the toxic effect was seen at dose 2. So this is called as TD50. This is called as TD50, because in humans, we do not have a lethal dose. You can't use a lethal dose, because lethal dose LD50 means the dose which kills the 50% of the, so that's mostly done in the animal studies. So wahan pe it will be LD50. So formula for therapeutic index is a mnemonic TILE. TI stands for therapeutic index, L stands for LD50 divided by ED50. So this is what you can, from one question we have Yes, divided by, yeah, it can be toxic dose divided by ED50, any. So even if now is question may say how many questions have we revised? So we have revised what is therapeutic index. We have done what is the formula or what does the graph area under curve denote. What tells you the extent of absorption? What tells you the rate of absorption? What is the formula for volume of distribution? And what is the formula for half-life? All of these are really, really important. And in case you are given a graph like this and 1 and 2 ki jagah there are values given. So let's say this is 10 and this is 60 and you're asked to calculate the therapeutic index. So will it be easy for you to calculate the therapeutic index here? Can you calculate the therapeutic index if this value is given? I have just written 1 and 2, but let's say actual values are given. So this one is 10 and this one is 60. So can you tell me about the therapeutic index here? Very good. It will be 60 divided by 6, which is divided by 10, which is 6. Yes, 6 will be the therapy. So you can be even asked that way. They give you the values and you're supposed to calculate, right? So more the difference between these two, higher is the therapeutic index of the drug. Okay? So in clinical practice, normally we call it a therapeutic range. Okay? We don't call therapeutic index, but therapeutic index ही होता है. Narrower is the therapeutic index, so there is less chance. मतलब 1 से 10, let's say this was 5 here, ठीक है, and this was 15 here. So now the therapeutic index would become 3. So that means this drug has a narrow therapeutic index. And which are the drugs which have narrow therapeutic index? Important ones to remember are your digoxin, lithium, ठीक है, digoxin, lithium, theophylline, phenytoin, valproate. These all drugs have very narrow therapeutic index. So they need constant monitoring. So please remember these. ठीक है, ये सारी drugs are very important. We'll be doing when we come to the questions individually of those drugs. But for now, remember they have very narrow therapeutic index. Right? Let's go on to the second one. Forced alkaline diuresis is effective in the management of poisoning by which of the following agents? Yes, very. Monitoring is definitely needed for a narrow index. Aspirin, no, aspirin cannot be monitored, because aspirin is a hit and run drug. Okay, so sorry, you are telling me the option to this. Excellent. This is the aspirin. A, yes. Excellent. This is the correct option. And why we say this is the correct option, and here what is important to know is acidic drugs, which are the important ones. You can't know all of them, but जो बहुत important ones है, we'll be telling about them, and the basic drugs. So funda इसमें यही है, acidic drugs, acidic medium, they remain unionized. Basic drugs, basic medium, unionized. So if you cross this, they will become ionized. And absorption is best with which form? Unionized or the ionized form? Absorption is better with which form of the drug? Ionized or the unionized? Yes, absorption किससे better है? Very good, Dhaval. It is the unionized form. So poisoning में definitely we do not want any absorption to take place. So we want to make the medium such that the drug gets inside and it gets ionized so that it cannot be absorbed back. So acidic drugs को ionize करने के लिए we need a basic medium. So we make the urine alkaline or basic in nature. And basic drugs को निकालने के लिए for yes, ionize will definitely excrete, not be absorbed. That's the whole purpose of for the poisoning. We do not want any absorption. So basic drugs, if you want to excrete it out, you have to make the urine acidic. So basic mainly you give sodium bicarbonate, so it makes the urine alkaline. For acidic, we can use vitamin C, ascorbic acid, or you can use ammonium chloride to make the drug more acidic. Now, which are the few important examples which have been asked before of the drugs, whether they are acidic or the basic? The first one we talked about is aspirin. ठीक है, the first is aspirin. Then there was once a question about phenobarbital. This is also an acidic drug. So if the question is instead here phenobarbital, again you will make the urine alkaline. Then yes, acetazolamide, right? Phenytoin. So these are all acidic drugs. So for them, you need to make the urine more alkaline. Now, basic drugs. So easy hai. The basic drugs usually they end with INE. Okay, most except for one, mostly they end with INE. For example, we have a drug here, morphine. So morphine is a basic drug. Okay. Atropine. Okay. Amphetamine, right? Cocaine. So all these drugs are basic drugs. Exception here to the AIN rule is your diazepam. So no need to remember all of them because the ones which have been asked previously, so I've tried to note down these. So all these drugs ending with "ene", at least you know that they are the basic ones, not the acidic ones. So here, then you will choose the option as making the urine more acidic. So vitamin C or ammonium chloride can be given in this case, right? All right, let's go on to the third one. Now, which of the following is not a prodrug? It is, remember, it is not a prodrug. Yes. Which of the following is not a prodrug? 4. Enalapril. Okay, Dhwani says enalapril. Dr. Raj says enalapril. Okay. Primidone. Dhaval says primidone. Okay. Quick, quick. Question is not. Varun says 1. Okay. Gokul says acyclovir. Alright. So we have all the options here. Now, see, it is not a prodrug. The correct option is number 3. Yes, Dhaval. So good. It is number 3. All the others are prodrugs. Okay? All the others, dipivefrin is a prodrug. All of them are prodrugs. Okay? Dipivefrin is a prodrug of epinephrine. Okay? Acyclovir gets activated to acyclovir triphosphate. ये active form है इसका. Enalapril, please remember, all ACE inhibitors are prodrugs, except I will tell you, enalapril is a prodrug, and जो prils हैं, because they are ACE inhibitors, when they get activated, they get converted to prilat. So enalapril, enalaprilat. All the ACE inhibitors are prodrugs, exception. Remember the exception to the rule. Don't remember others. Except hai captopril. Very good. Very good, Dhaval. Captopril and lisinopril. Yes, yes. So except yaad rakhna hai. Don't remember the others. So they are not prodrugs. Okay? So all of them. Now there are few important, if you want to remember, few important drugs which are prodrugs. Remember this mnemonic which is bad sample. Okay, I'll tell you a mnemonic which is bad sample. BA, bacampicillin. Okay, for ampicillin. D is your dipivefrin, which converts to epinephrine. Okay. S is your sulfasalazine, converts to 5-amino salicylic acid. A is your acyclovir, right? M is for mercaptopurine. You don't have to remember actually the metabolites. Just important I will tell you. But these are the examples that they ask you. Okay? Prednisone, which gets converted into prednisolone. Even proguanil, P se proguanil bhi aata hai. Alright? L say, very important, is L-dopa or levodopa, which converts into dopamine. And E is one of the ACE inhibitors, enalapril. Is this help for USMLE? Yes, I think some questions are quite similar. You can see the pattern in the USMLE, but questions don't change in pharmacology much, you know. So they have a clinical twist to that, but you can obviously gain from any of these questions. Yes, why not? So please remember this mnemonic of batch sample. Okay? So most of the times, any में they ask you, these are the important drugs, which are your pro drugs, right? So, and ACE inhibitors, please remember without any doubt that all of them are pro drugs. So, kabhi bhi mark nahi karna. Unless until there is captopril, lisinopril given, they are all are pro drugs. Right? Good to go? Very good. All right. Now, this is another commonly asked question. Identify the type of inhibition from the given graph. Identify the type of inhibition from the given graph. Competitive, Dr. Raj. Excellent, excellent. So this is competitive. Very good. Very good, Dr. Ravi. So here I didn't give you options. I just wanted you to, all of you are correct. So this is called as the Lineweaver-Burke plot. And here I would not recommend you do anything else. Just remember these pictures and remember the figures and remember the type of the type of inhibition shown. Okay? So easy trick to remember is, if a graph it looks like a cross. Okay? It looks like a cross. Cross is with a C. So it is your competitive inhibition. Okay? Cross. C for cross, C for competitive inhibition. If it looks like a V, okay, then it is your non-competitive inhibition. Non-competitive inhibition. And the other shape, it almost is like a U. Okay? It's like a U. So this is your uncompetitive inhibition. Just remember this: competitive, uncompetitive, non-competitive. Even if you remember two, competitive and uncompetitive, because of the shape, you can easily make out कि जो V है, that is your non-competitive inhibition. Now, what is another important thing here to know is the Km and the Vmax, which is asked especially for the competitive and the non-competitive. So it's given here, the Km and the Vmax. So competitive mein, if I have to actually draw here, the other one, this is without any inhibitor. And let's say I have this graph here, another graph, and there is or let me make another color here. Okay, so this is graph B and this is graph A. Now out of this, can you tell me A and B, which is competitive inhibition and which is the non-competitive? A and B में से, from this one, the one which I have drawn, out of A and B. Yeah, that is okay. Tell me which is competitive and which is non-competitive. Jamshed, I think, see this, if you see this picture, this is actually from the USMLE topics only. So I don't think so that there is anything which will not be helpful to you in USMLE. Why not? So I would suggest yes. Okay, Dr. Raj, Dr. Avi. A is competitive, B is excellent. A is competitive here and B is non-competitive. ठीक है, competitive and non-competitive. So competition के लिए you need a little more work, ठीक है, but you can reach the same level. So therefore the km, the effort is more dose is required, but ultimately you can reach the same height. ठीक है, ये same height achieve कर सकते हो if you are working really hard. So in competitive the maximum velocity is always the same, but the km will definitely be high, the dose required to reach that. Non-competitive is like the Vmax is reduced. So non-competitive में क्या है? The Vmax gets reduced because there is distortion of the site where the substrate has to attach. So substrate ही destroy हो गया. So basically you, whether the affinity doesn't change, but the problem is the Vmax और जो है वो you cannot attain the same level of जो कहते हैं Vmax velocity because the site has been distorted. तो इसमें जो B है it will show you a drop in the velocity, तो fall in the performance आ जाएगा इसमें. So please remember even this graph can be asked. ये तो मैंने line plot पूछा है, that is there. The second one, even this has been asked, identify which is the type of inhibition and the Km and the Vmax. So ये सारे की सारे चीजें they are important, right? All right, let's go to the next one. Which of the following is given by the IM route via the Z technique? Z technique, it's a Z track technique जिसको हम कहते हैं. Which of the following is given? Dr. Raj says 2, okay. Agat says 2, all right. Yes, this is absolutely the correct option. Iron and even antipsychotics. Okay, so they are both given by the Z technique. And actually this Z track technique is the main aim is to not allow the drug to come back from the muscles to the subcutaneous tissue, because एक तो wastage है, all the drug doesn't go into the muscles, and secondly it can irritate the subcutaneous tissue. You see you have, देखो ये आपका skin है, it has epidermis, it has dermis, it has your subcutaneous tissue, and then let's say this is the muscles. This is the muscles. So when you're giving an injection, the aim of the injection is to reach this side. Okay? So here you have to give an injection. Now what they do in the Z technique is they will try to, whenever you are giving the injection, they will try to first stretch the upper layer. The skin hai, they will try to stretch it. So the dermis and the epidermis, they'll try to stretch this. So when this is stretched, definitely what will happen, जो epidermis and dermis है थोड़ा stretch हो जाएगा, and it will move to a little one, this direction. See here, this will come here, it will be stretched, and this will not be there. Thoda stretching. Now they are going to give the injection, and this is the injection, how you give the injection. This is the point of injection here, and you put the needle, syringe goes here, and ultimately the drug is delivered here. Then you wait for 10 seconds, because immediately if you withdraw, it will lead to backflow of the drug and it will go into the subcutaneous tissues and all, and it is supposed to go into the muscles, absorb nahi hogi muscles se, so it will not give you 100% of the results. So after this injection has been given, you wait for 10 seconds and then leave the skin. So when you leave the skin, again this is like this, and now this mark over here, jo pehle it was here, it has reached this point now because you have released that skin. So if you try to make it, it looks like a shape of a Z track technique. So basically Z track technique, the aim of Z track technique is to decrease the backflow of the drug from the muscles to the subcutaneous tissue and decrease the wastage of the drug, and so that much zyada se zyada drug can be absorbed and the effect can be seen. And another example of the drug which is given by this is your antipsychotics, because nowadays they recommend almost all the intramuscular drugs should be given by this, but currently the examples are iron and antipsychotics, right? All right. Now, the another very common question which is asked: which of the following correctly describes the phenomena of the vasomotor reversal of Dale? Vasomotor reversal of Dale. First is repeated administration of ephedrine decreases its effect on blood pressure. High dose of acetylcholine after pre-treatment with atropine produces rise in blood pressure. Pre-treatment with phentolamine followed by administration of adrenaline causes hypotension. Increase in the pulse pressure is produced by IV administration of isoprenaline. So which is the correct option here? Vasomotor reversal of Dale. Which of this represents your vasomotor reversal of Dale? Dhwani says 2. All right. Agat says 3. C. Yeah. Okay. More options. More. Asik says C. Dr. Raj says C. Dhaval says C. Induja says B. Okay. So see, the correct option here is, do not forget this, very important, is it your C. Pre-treatment with phentolamine followed by administration of adrenaline causes hypotension. Okay? So let's see what is this vasomotor reversal of Dale. So this is actually a graph taken from, there are now computer simulated experiments, because now we do not actually use dog experiments, dog experiments. So these are computer simulated programs where you inject a drug and you get the response. This is one of the graphs taken from that response. So see here, what you see is that we are giving here, this is a drug which is I am giving, yes, it is PYQ, it is a PYQ. They would give you a graph, they might give you a graph like, see, this, and they will ask you what is this technique. Okay, and they will give you drugs, यहाँ पर दे देंगे epinephrine, okay, and then they will ask you second, what is this response due to? So let me explain you what is this first, right? Let's go into the in-depth. So this is high dose of adrenaline. Now we'll break this graph into bit by bit and then understand each and every point, because there are two important questions in this graph. Very good. And beta stimulation, alpha blocker and beta stimulator. Yeah, definitely. First is high dose of, please listen to my question carefully. High dose of adrenaline we are given, and this is the response that we are getting. So my question is, what is this response called as? My question is, what is this response called as? The first part mein, what is this response called as? They will give you this part of the graph and they will ask you, this is because of high dose of adrenaline, low dose of adrenaline, high dose of noradrenaline, low dose of noradrenaline. So I've already told you this is a graph which is got from high dose of adrenaline. But I want you to answer me, what is the name of this response? Anybody? What is the name of this response? No? Okay. No, that is the second part. Vasomotor Dales is the second part. I'm asking the first part. ये पूरा vasomotor Dale नहीं है. Vasomotor reversal of Dale is this part. ठीक है? So don't confuse. This is vasomotor reversal of Dale. This response is called as the biphasic response. Right? This is called as the biphasic response because it has two phases. One is this rise in the BP and the other is a fall in the BP. Rise in BP is because of the effect on the alpha 1 receptor. This fall is because of the effect on the beta 2 receptor. Will noradrenaline show this effect? No, because it has no effect on the beta 2 receptors. So noradrenaline will not show this biphasic response. It is only seen because of adrenaline, as they have they have effect on all the receptors. Okay, all the sympathetic receptors. Okay, so this is your biphasic response. Now इसमें क्या हुआ है? You have given high dose of adrenaline, and here let's say you have given a drug which is, जो हमने इस response में किया, that is phentolamine. ठीक है, phentolamine. What is phentolamine? Phentolamine is a alpha blocker, non-selective alpha blocker, right? And after you've given phentolamine, you have again given adrenaline. After giving phentolamine, you have again given adrenaline. But now, do you see the biphasic response? No. What response is seen? Only, no, it is not cheese reaction. Please do not confuse. It is not cheese reaction. Cheese reaction is not because of blocker. Yes, it is phentolamine is an alpha blocker. But when you give adrenaline, there is only fall in the blood pressure seen. ठीक है, यहाँ पे दिख रहा है, this is only the fall in the BP. This one. सिर्फ fall. Why? Because the alpha receptors have been blocked by phentolamine. The only available receptor which is present on the blood vessels for adrenaline to act is your beta 2 receptors. Or beta 2 receptors, they cause fall in the blood pressure. And this is the response that you're seeing, fall in the blood pressure. So phentolamine is an alpha blocker, non-selective blocker. And after that, when you again administer adrenaline, the only response which is seen is the fall in the BP, because there is no effect of adrenaline on the blocked alpha receptors. Only effect is on the beta 2 receptors, which shows as a fall in the blood pressure. And that is your hypotension. Yes, alpha blocker. Why alpha blocker will cause hypotension? If this, and its clinical relevance, what is the clinical relevance here? Clinical relevance is in a condition which is called as pheochromocytoma, right? You have heard of pheochromocytoma, tumor, okay, of the adrenal gland, where there is a lot of catecholamines released. So in that there is high amount of catecholamines, and they will cause high blood pressure. You know that alpha receptors, a high dose may the alpha effect predominates, so there is high BP. So there the drug of choice for you would be giving an alpha blocker, right? First, yes. So first you have to give an alpha blocker. But what if you do not give a beta blocker later on? What if you do not give a beta blocker later on? Only you're giving an alpha blocker. So whatever adrenaline is present, it will act on the beta 2 receptor and cause drastic fall in the BP. Hypotension. Patient will die of hypotension now. So therefore it is must that first you give an alpha blocker and then you give a beta blocker. Okay? Then you give a beta blocker, because you have to take care of the tachycardia also. They will take care of the beta 1 receptors also. That is important. Or दूसरी चीज, another important thing is, if you give beta blocker before, what will happen if you give a beta blocker before? Beta receptors are blocked, alpha receptors are still vacant. So all adrenaline is going to act on the alpha receptors, and there will be tremendous rise in the BP. Hypertension already was there, now that will shoot up the floor of the roof. So that is also not advisable. So the correct treatment of pheochromocytoma is, yes, you give alpha plus beta. See, the efficacy is much better because they are not effective on all the receptors. You can use labetalol and all, right? So, but better is that you use drug which is non-selective. Okay? So, alpha pehle, and then you can use the beta blockers. You can use that also. So, this is the correct response. Now, let's discuss the other things if they're asked. So, your first option tha here, repeated administration of ephedrine decreases its effect on BP. Is it a correct statement? Let us answer nahi hai, but you know what this is phenomena is called? Repeated doses of ephedrine decreases its effect on the BP. Is it true or false? Ephedrine, if you give on repeatedly, will it decrease the BP? It's if you give it repeatedly. Tell me, true, false? False. Why? True. Why? True. Yes, it is true. Because, very good, it is tachyphylaxis. So, because it is because of the indirect action, indirectly acting sympathomimetic. So, if you go on giving it repeatedly over a short duration of time, repeated over less than half an hour, matlab you're not giving time to synthesize the neurotransmitter. So, when you give on giving it repeatedly, there will be fall in the BP. So, this is called as excellent tachyphylaxis. Then second is high dose of acetylcholine after pre-treatment with atropine produces rise in BP. Is it correct? High dose of acetylcholine after pre-treatment with atropine produces a rise in BP? Yes or no? See, PYQ self correct option is not the only thing that we need to do. We need to do the other options also, because the next time they may give you something from the other options. So it's always understand the importance of the other options also. High dose of acetylcholine after pre-treatment with atropine produces rise in BP. True, very good, Varun. True. Because of the effect on which receptor? Because of what? What? Effect on which receptor? Atropine. You have given atropine before, right? So atropine is a muscarinic blocker. No, muscarinic nahi. We have already blocked this, Varun. एट्रोपिन ने मस्करिनिक रिसेप्टर को ब्लॉक कर दिया है, ठीक है. सो यू हैव गिवन अ मस्करिनिक ब्लॉकर and then you are giving acetylcholine. So how will it cause rise in BP by acting on the muscarinic receptor? When you have a very high dose of atropine, ठीक है, and you know that acetylcholine जो muscarinic होता है receptor और जो muscarinic action है, it causes the release of EDRF and that leads to vasodilated effect, not rise in BP. It lead to fall in the BP. ठीक है. Yes, excellent Dhaval. NN, nicotinic action. Acetylcholine is a non-selective agent. It will act on the muscarinic as well as the nicotinic. But nicotinic action usually comes at a higher dose. So when you have already given atropine before, it has blocked the muscarinic action. The only receptors available are nicotinic. And nicotinic receptors, when you give a high dose of acetylcholine, because there is no muscarinic receptor to act, it will now only act on the nicotinic receptors, N type of receptors. So these receptors are present in the autonomic ganglion. They are also present in the adrenal medulla, where they cause, और वहाँ पे क्या करते हैं? They cause release of catecholamines. And you know what catecholamines do? They cause rise in the BP. So this is again a true statement, but the action, if the question is this action is because of action on which receptor, it is not muscarinic, it is your nicotinic receptor N type. ठीक है, N type. Then third we have discussed the fourth option. This was also asked in another MCQ before. Increase in the pulse pressure is produced by IV administration of isoprenaline. True, false? Increase in the pulse pressure is produced by the IV administration of isoprenaline. Yes, is it a correct statement or false? All right. Why, Rohit? Why is it false? What should be the correct option then? You're absolutely right. Only heart rate increases. But what about the mean BP? Mean blood pressure. What happens to the mean blood pressure when you're giving isoprenaline? No, isoprenaline has effect on beta 2 also, not only beta 1. It has effect on both the beta 1, beta 2 agonist. See, what it does is it has effect on beta 1. Okay? It has effect on beta 1. And this leads to increase in the heart rate, cardiac output. So it will definitely, what it will do, increase the systolic blood pressure. Okay? It will increase the systolic blood pressure. But it also has effect on beta 2, where it causes vasodilatation and causes decrease in the diastolic blood pressure. But the magnitude of effect on beta 2 is much more than beta 1. Ultimately, there will be a fall in the BP. So there will be a decrease in the blood pressure, not increase in the blood pressure. Okay? And whenever there is a decrease in the blood pressure, there is reflex tachycardia. So it can lead to, there will be an increase in the heart rate, that is also there, plus also there is reflex tachycardia. So isoprenaline causes a fall in the blood pressure ultimately. Okay, so all these 4 options are very important to understand, and in future if you get question on any of these, I'm sure that now you will not make any mistake. Okay, let's move on to the next one now, which is applied as a patch for motion sickness. Which is applied as a patch for motion sickness. Atropine, scopolamine, cinnarizine, nicotine. No, Ashik, NM ki baat, we are not talking about NM. NM is neuromuscular junction. I was talking about NN, on the autonomic ganglion. So if you see the actions of acetylcholine, it will act, acetylcholine acts on both muscarinic as well as the nicotinic receptors. The action on nicotinic receptors like NM is different, NN is different. But now what you've given is atropine. Atropine ne kya kiya? It has blocked the muscarinic receptor. So when you give a high dose of acetylcholine after you have given atropine, now muscarinic effect can no longer occur because it is already blocked. Now the nicotinic action is there. Now because of its action on the NN, NM doesn't have an effect on this particular point which I'm discussing, the high blood pressure effect. It has an effect on the NN. If you go and read, NN kahan present hai, autonomic ganglion and also on the renal medulla. So what it does is it will go and stimulate that, and when the medulla and adrenal is stimulated, releases catecholamines. Catecholamines release हो गए, adrenaline and all, और उनका क्या काम होता है? To increase the blood pressure. So ultimately that effect है. Indirectly there is an increase in the blood pressure. So that is the reason for high dose of acetylcholine causing a rise in BP once you have given atropine. Okay, that is the reason. All right, so you all of you are giving me the answer as scopolamine. Excellent, very good. Scopolamine applied as a patch for motion sickness. Scopolamine, and the other name is hyoscine. So this is the drug which is given for motion sickness. Okay, and patch है, a transdermal patch. ये it is applied. ये आपका अगर this is the ear, this patch is applied behind the pinna. ठीक है, behind the pinna we apply the patch, and it should be ideally applied 4 hours before, because it's a transdermal patch. Slowly and slowly the drug is going to be released, right? Now 4 hours I think it's fine, or a day before. It has to be, it works for about 3 days. If you're giving an oral tablet, then you can give half an hour to 1 hour before, but if you're giving a patch, you need to give it much before. So 4-5 hours before you give, and slowly it will release the drug, and it will be effective in these patients for about 3 days also, right? So this is, so why is this important for motion sickness? And you know that in the yahan pe in the ear there is something which you call as the vestibular apparatus. Vestibular apparatus, ठीक है? So in motion sickness, so this gets stimulated, overstimulated, and the impulses from this, they go on to the cerebellum, and then they go on to the vomiting center. And which are the important receptors here? Your muscarinic receptors and the histamine receptors. So you have to block this pathway. So either you can give a blocker of muscarinic, or you can give a blocker of the histamine. So cenarizine and like drugs are the histaminic blockers, and muscarinic ke liye we have scopolamine. Now, okay, so here scopolamine is an ideal drug. So why can you not give atropine here? My question to you is, why you cannot give atropine here? Any guesses? Or if you know, you can answer. Why can't atropine be given in this case? Because atropine is not much lipid soluble. Okay? No, not lipid soluble. It is not lipid soluble. It will not be able to enter. Okay? So hyoscine is much more lipid soluble. Therefore, atropine cannot be used. So remember this. Okay? All right. Let's move on to the next question here. Which of the following is not, which, whenever you read the question, please read, not some, more often asked. Which of the following is not an adverse effect of Raytodrine? Which of the following is not an adverse effect of Raytodrine? Hypoglycemia, hypokalemia, tremors, tachycardia. Dhaval says 1, Dr. Raj says 1, which is hypoglycemia. All right. That's all. No other. Come on. Hypokalemia. Okay, Basharat says hypokalemia. Asik says hypoglycemia. All right. See the, please read the question. It is not. Okay, not. Don't forget the not here. All right. So the correct option here is, most of you have responded, it is your hypoglycemia. What is the correct? Instead of this, it should be, होना क्या चाहिए था? Instead of this, it should be what? It should be hyper. Very good, Dr. Raj. Hyperglycemia. So major. And what is Raytodrine? Raytodrine is a beta 2 agonist. Okay? Isoxpurine, Raytodrine, these are the drugs acting on the uterus. And then salbutamol, right? Terbutaline, these are the beta 2 agonists which are used for the management of asthma. Okay? So these are the beta 2 agonists. The major adverse effects of beta 2 agonists are, if you remember, T3H3. T3H3. So T, yes, H, and H. One T is for tremor. Okay? One T is for tolerance. So if you go on giving it repeatedly, especially longer acting drugs, tolerance develops to the action. The third T is for tachycardia. But this doesn't occur at low dose. Tachycardia is only at high dose. And the reason is, at high doses, the selectivity is lost. It is no longer acting only on the beta 2 receptors. They also start acting on the beta 1 receptor. So high dose mein the selectivity is lost. So tremors, tolerance, tachycardia, 3 T's. What are the 3 H's or H3? This is hyperglycemia. Hyperglycemia. And the reason for hyperglycemia is glycogenolysis. Okay? Hyperglycemia. hypokalemia and hypotension. ठीक है, T3H3, 3 T's and 3 H's. Easy. Now you will remember. So इनमें से अगर whatever is not there will be your answer, which is not an adverse effect of beta 2 agonist. Okay. Now another very important question is dose of adrenaline for anaphylactic shock. I'm not giving you any option here. You just have to tell me the dose of adrenaline for anaphylactic shock. You should know the dose, you should know the concentration, and you should know the route here. Three of the, so tell me the dose, tell me the concentration, and tell me the route of choice. Yes, tremors. Quite often, tremors is very common. Excellent. You're telling me the concentration. Yes, Varun and Dhwani, that is perfectly fine. Absolutely, it is 1 in 1000. Now, what is the dose? Dr. Raj has told me the preferred route also. अब रह गया dose. How much? This is the concentration. ये dose थोड़ी है अकेला. This is the concentration. But how much to give? Very good. 0.5 ml. Excellent. So this completes your answer. 0.5 ml, 1:1000 by IM. IV, no IV, no IV. IV में patient मर जाएगा. ठीक है? Because this is a very high dose for IV. IV, if you want to give, at first route of choice is IM. IV देना है, you need to dilute this further. If you give this IV, patient will die because of tachycardia. ठीक है? Arrhythmias. So do not give by IV route. This concentration, no, not at all by IV route. So let's do the important concentrations which are must for this. Yes, Asik. गलती से भी IV मत लिख देना, ठीक है? So dilutions of adrenaline and its use. So अभी हमने किया 1:1000, right? IM and 0.5 ml. This is one thing. If you dilute it further to 1:10,000, it can be used in cardiac arrest, and this can be used in epistaxis. You know, it's a vasoconstrictor, okay? So it can be used in epistaxis, nasal bleeding. 1:2 lakhs. It is used along with local anesthetics as a vasoconstrictor, okay? Along with local anesthetics as a vasoconstrictor, where it will increase the duration of action of local anesthetic. It will decrease the systemic absorption of local anesthetics. So it will lead to decrease in the side effects of local anesthetics, and it will decrease the bleeding. जहाँ पे आप surgery हो रही है. So this is, let's say the surgery is taking place here and you are giving local anesthetic here. So if you give a vasoconstrictor, the drug will remain in this area. It won't be absorbed in the body, in the other. Okay? So that is the main role of the using a vasoconstrictor along with local anesthetic. So this is, but exception क्या है? Where you should not give this? Where you should not give adrenaline with the vasoconstrictor, with the local anesthetic. Where you should not give. Okay. So 4 zeros is 10,000, right? So therefore, yeah, it's not 1,000. So 4 zeros is 10,000. Pheochromocytoma, no. Okay, that is another. I'm saying where you are doing anesthesia. You are doing anesthesia here, right? आप local anesthetic देना चाहते हो, but you cannot give a vasoconstrictor. Okay, that is fine. Okay, I will, that is another. Yes, very good. Which part of the body? Yes, excellent. End arteries. End arteries में जहाँ पे, for example, tip of the finger, pinna, वहाँ पे end arteries में you cannot give a vasoconstrictor because, yes, ear lobule or pinna, then you cannot, if you give a vasoconstrictor, there will be decreased blood flow to that areas, can lead to gangrene. So वहाँ पे you cannot use vasoconstrictor with the local anesthetic. Very good. Excellent. Yes, and arteries. All right, let's get on to the next one now. This was also recently asked. A patient has glaucoma and is suffering from bronchial asthma. Which of the following anti-glaucoma drugs should be avoided in this patient? Yes, this is very easy. Okay. Time and again asked. 2. Pilocarpine. See here, this is something which you have to take into consideration. They have given you the hint here. So which of the drug is contraindicated in bronchial asthma? That's your hint here. Timolol. Very good. Timolol. Yes, yes, excellent. It is the beta blocker. So non-selective beta blocker. It is a non-selective beta blocker. Excellent. They should not be given in patients suffering from either they have a heart failures or AV blocks or bronchial asthma. Now this glaucoma topic is a very, very important high yield topic, and all aspects are important. Adverse effects, mechanism, everything is important. So let's just briefly get into what are the important things that you should know about these drugs. Okay? So before I go further, you know what is pilocarpine? It's a miotic, okay, which is helpful as in patients of glaucoma. Betoxolol is also there. Why did you not opt for betoxolol? Why only timolol? Why did you not choose betoxolol as an option? Yes, it is selective, especially it's active beta 1. Okay, it is selective. Excellent. Brimonidine is a alpha 2 agonist. Okay, clonidine congener. Let's get further. Very good. Very good, Rohit. Very good, Varun. Chalo ji. Adverse effects of drugs used in glaucoma. For timolol, okay, firstly it is contraindicated in patients of bronchial asthma. Okay, contraindicated in patients of bronchial asthma. It can cause stinging sensation, burning in the eye, and it can lead to blepharoconjunctivitis. Coming to the most often asked adverse effect is of this drug, which is latanoprost. It's a prostaglandin analog, and you know this is the drug of choice for open angle glaucoma. Yes, burning or stinging, I said. Yes, hypertrichosis, and this is a case of hypertrichosis, which means increased growth of eyelashes. They become long and thick. Hypertrichosis, and this is called as pigmentation of iris. Heterochroma iridis. Iris becomes pigmented. Heterochroma iridis. ठीक है? Yes. So latanoprost has these two. One is this, second is this, and third it can lead to macular edema. Okay? Third, it can lead to macular edema. These three are the must-know side effects for latanoprost. Coming to the other drugs which are important side effects are apraclonidine. Apraclonidine. इसका जो important है, that is lid retraction. Very commonly asked, lid retraction. And in the newborns, it can cause apnea. Apnea in the newborns. Therefore, it cannot be used in young children. Less than 2 years, it cannot be used. For apraclonidine. Yes. Very good. Yes, lid retraction. Acetazolamide can also lead to corneal edema. ठीक है, corneal edema and ocular allergy. Yes, sulfur जो भी any drug which has sulfur moiety in that, definitely they have a tendency to cause allergic reactions. Nitarsudil, rho kinase, a newer drug, rho kinase inhibitor, it can cause redness in the eye, red eye. ठीक है? Yes, very good. Corneal edema. Epinephrine can cause conjunctival pigmentation. Conjunctival pigmentation. So remember the difference between epinephrine and latanoprost is latanoprost causes pigmentation of the iris, epinephrine causes pigmentation of the conjunctiva. Okay, that is the difference between the two. So see the question, if it is asked which of the following causes heterochroma iritis, then it will be latanoprost. If the question is on the conjunctival pigmentation, then your answer becomes epinephrine, right? Great. Now, next, quickly let's do which are the mechanisms. Equally important are which drug acts by what mechanism. Yes, let's have it from you. Drugs or drug which increases the uveosacral outflow. Drug which increases the uveosacral outflow, or drug which increases the, very good, or the prosts. Yes, prosts, your latanoprosts, right, bimatoprost, they will increase the uveosacral outflow. Drug which increases the trabecular outflow. Trabecular outflow. Miotics, yes, very good. Miotics like pilocarpine, physostigmine, and even nitarsudil. You can add this also, nitarsudil. Drugs decreasing the aqueous formation. Drugs decreasing the aqueous formation. इसके लिए you remember A, B, C, D. Drugs decreasing the aqueous formation. A is for apraclonidine. B is for beta blocker. C is for carbonic anhydrase inhibitors like your acetazolamide. D is for dipivefrin. जो हमने किया था is a prodrug of epinephrine. So A, B, C, D are your drugs which are going to decrease the aqueous formation. Correct? ठीक है? So these are some important points about the drugs used for in glaucoma. Mechanism and side effects very important. ठीक है? And latanoprost or prostaglandin analogs are the drugs of choice for open angle glaucoma. ठीक है? Right? Let's move on further. Another important question is asked many times. Which of the following statement is incorrect? Which of the following statement is incorrect? Carbamates bind to acetylcholine esterase irreversibly. Atropine is used as an antidote of organophosphate poisoning or phosphorus poisoning. Pyridoxime has a role in the treatment of carbamate poisoning. Atropine is used as an antidote for carbamate poisoning. Dhaval, Rohit, and Dr. Raj says 3. Varun says 4. 3, 4. Okay. Yes, yes, very good. Excellent. So the correct option is 3. 4, why do you write 4? Atropine can be used in any. Atropine is only supposed to block the muscarinic receptor, right? So muscarinic 1 and 4 are incorrect. Why? Why is 1 and 4 incorrect? 4 is used, atropine is used in both of them, because what is the role of atropine? Atropine has to block the muscarinic effects of acetylcholine. So whether it is carbamate, whether it is organophosphate, they are going to block the acetylcholine esterase enzyme, and they are going to increase the levels of acetylcholine. Or wo jo acetylcholine levels are high, they are going to act on the muscarinic receptors as well as the nicotinic. But most of the problems are seen because of action on the muscarinic receptors. So what atropine is going to do, it is going to block the atropine receptors. So it will work in both, okay, and they are irreversible, okay. So it will work in both. So this is absolutely correct. ये दोनों में use कर सकते हैं, मतलब can be used. So the incorrect option is this one. Pralidoxime has a role in treatment. जो है cholinesterase reactivators like PAM, DAM, they don't have any role in carbamate poisoning. And the reason why don't they have any role in this carbamate poisoning is because if we see the structure of the acetylcholine esterase enzyme, it has two sites, right? One is the anionic site and one is the esteratic site. Esteratic site spelling. I'm just correct. Right? Yes, very good, doctor. The carbamates bind to both. Organophosphate or phosphorus compounds, they only bind to the esteratic site. So anionic site is free, and your pralidoxime PAMs, they need only this site to bind. So they will bind to the anionic site and they will form a phosphorus bond with organophosphate and it will remove it from the site. Yes, but the problem with carbamates is this color. Carbamates, they occupy both. ठीक है? ये जो carbamates हैं, they occupy both the sites. So there is no site available for action of the pralidoximes. So therefore, they are ineffective in this. Atropine definitely is the treatment of choice for OP poisoning or carbamate poisoning. And for atropine, you should know that you for this it is important 0.2 ml IV route given every 10 minutes till the signs of atropinization occur. ठीक है? Very very important. Antidote for OP poisoning or carbamate poisoning. ये question है. Is your atropine. ठीक है? All right. Coming to the next question here. What is the mechanism of action of the TPA? TPA is the tissue plasminogen activator. What is the mechanism of action of TPA? One. Dhaval says one. Fibrinolysis. Okay. Bhavani Shankar says one. Okay. Dr. Raj says one. Very good. All of you are absolutely. Asik says one. Very good. Absolutely correct. It is fibrinolysis. Yes. Perfect. Fibrinolysis. So, what is the role of? Very good. So, what they do is plasminogen converts into plasmin, and this plasmin causes the degradation of fibrin to fibrin degradation product. It causes the lysis of fibrin, and what is required here is your tissue plasminogen activators. So can you name drugs which are going to stimulate this function of the or increase this process of fibrinolysis? Yes, PAM is mostly for the other functions apart from the muscarinic. Yes. Very good. Streptokinase. Streptokinase. Urokinase. So ये और tenecteplase. Very good. Tenecteplase. Alteplase. Very good. So these are the recombinant tissue plasminogen activators. Urokinase is not used much because ये available मिलता ही नहीं है because it is cultured from the kidney cells. The Streptokinase has a problem of causing allergic responses. So once you use it, you cannot use it again if the patient becomes allergic to that. So basically, we are preferring these two. And which are the drugs which inhibit this step? Which are the drugs which inhibit this step? Or you can say they are the antidotes for this, which inhibits this step. The most common is tranexamic acid and no, not heparin, NEACA. Tranexamic acid and EACA. Okay? These are the drugs which inhibit this process. Remember this. And if I go back to the question, if you're talking about Varun, heparin, the major effect of heparin is this one. Okay? It inhibits factor. कौन से factors inhibit करते हैं heparin? Which factors? Aspirin? No, aspirin कहाँ से? Aspirin is an antiplatelet. Aspirin is a COX enzyme inhibitor. Thromboxane A2. Not here. No. Factor 10 and factor 2. It inhibits the activation of factor 10 and factor 2. That is heparin for you. Yes, very good, Dhaval. What is the difference between low molecular weight heparin and heparin? Effects. Low molecular heparin. Factor 10 effect is much more than factor 2. And just the third is fonda parinux. Okay? Yes, monitoring is also, because the reason is this only, because it inhibits factor 10, factor 2, massive effect है ना, तो उसका effect उतना ज़्यादा नहीं है. Fonda parinux only factor 10. ठीक है? It is actually inhibiting the activation of 10 to 10A basically. That is the rule. ठीक है? Yeah. So ये तीन difference है, heparin, low molecular heparin and fonda parinux. And here if I come to one question, what is the antidote for heparin overdose? Antidote for heparin overdose. Very good. Protamine sulfate. Protamine sulfate. Shabash. Excellent. Protamine sulfate. So let's go on to the last question of today. Okay? A 25-year-old female patient was taking warfarin for prosthetic heart valves and she becomes pregnant. So what advice will you give to her? Continue warfarin without any concern. Continue warfarin but add vitamin K to the therapy. Switch warfarin to heparin or terminate the pregnancy. One, two, okay. 2, 3, C, 3, 3. Very good. So the correct option is you have to stop warfarin. Warfarin cannot be given in pregnancy. Warfarin is teratogenic, cannot give to a pregnant female. You have to switch over from warfarin to heparin. Okay? So let's see if you can identify. These three are the classic fetal syndromes. If you can tell me which one of this is which syndrome, because of what drug. These are fetal syndromes. Three most important drugs that you should know. And which causes what, if you can identify. The first picture, if you can tell me. This is because of which drug? See the here, highlight is your cleft lip. ठीक है, cleft lip है यहाँ पे. No, this is not warfarin. Let's say picture number 1. You can tell me picture number 1, picture number 2 and 3. So you can give me 1, 2, 3. Yeah. So but which toxicity, कौन सा teratogenic drug है यहाँ पे? Warfarin is not one. First is not warfarin. This is not the one. First one. Very good, Dhaval. Two is alcohol, fetal alcohol syndrome. Excellent, Shafkat. This one is, first one is fetal Hayden-Toyne syndrome. That is because of phenytoin, fetal Hayden-Toyne syndrome. This is fetal alcohol syndrome. If you get this picture, where the upper lip is very thin and this philtrum जो होता है यहाँ पे, there is no philtrum. It is very smooth skin, no philtrum. If you touch your area above the lip, it has a groove. So इसमें there is no groove. It is very smooth. And the third one is your fetal warfarin syndrome. Fetal warfarin syndrome, and the classical feature here is this nose. If you see, you know, this called as nasal hypoplasia. Nasal hypoplasia. ऐसे अगर, if you see this picture, classical, this is a fetal warfarin syndrome, and they have very small eyes, microphthalmus. ठीक है, very small eyes. So ये three are the classical pictures. In case you get it in a picture form, this is typical of Hayden-Toyne, phenytoin. We'll be doing a phenytoin also in one of the questions tomorrow, and we'll discuss what are the important adverse effects of phenytoin. So this is one of the classic adverse effects, fetal Hayden-Toyne syndrome. Second is your fetal alcohol syndrome. Third is picture is of fetal warfarin syndrome. All right. So this was all about today's session. I hope you could make use of the important questions and the important points around that question. Not only the option, but each and every option needs to be revised, because what is important is not just the question. Question may not be repeated in the same fashion, but the topic is usually repeated. So you should know about the topics. So इसीलिए I discussed every option so that you have a fair idea of why. Asik, I'll continue tomorrow. ठीक है, don't worry, we'll have many more classes coming up and we'll be taking up such questions again. Don't worry, and you can continue recalling and revising. So it's always best. ठीक है? Okay. ठीक है, from here, अच्छा, let me ask you one thing. Okay, tell me about antidote for warfarin poisoning. चलो, antidote for warfarin poisoning. Warfarin का antidote बता दो. And then we'll push off, okay? Antidote for warfarin. No, not tranexamic acid. Vitamin K, excellent. It is vitamin K, Dhaval. Excellent, beta. Vitamin K. Why? Because warfarin का action क्या है? It inhibits the synthesis of vitamin K dependent factors. And which are those vitamin K dependent factors? 2, 7, 9 and 10. So warfarin inhibits the synthesis of vitamin K dependent factors. So if there is overdose of warfarin, you can always give vitamin K as an antidote, right? All right, with this we end today's session. All of you revise these questions, revise them as much as you can. That's the key to getting a very good rank, and nothing can stop you. And just if there is any other, we will actually go on revising such questions more often, so that you are on track at least with pharmacology with me, and there'll be no problem, right? 2, 7, 9, 10. Yes, Asik, very. Okay, guys. So thank you all, everybody. Take care. God bless. Study well.